I would then assess her prone and supine.
Okay.
So if you come and lie on your back first of all. So for the assessment of the actual diastasis, I'd get the patient to bend up the knees. And I'd do a palpation without strain. So I'd palpate between the two bellies of recti, and then I'd get her to lift her head and lie back down again. And now I couldn't bring a model with a proper diastasis recti, I'm sorry.
That's all right.
But so I could feel if there was more of a gapping, so hers is about a centimetre, so it's completely physiological. But I would otherwise then palpate the borders for density to just see how is the fascial glide of the borders. Is that okay? Mm-hmm. So I'm just going to go down all the way the middle line. And then I'd get her to periodically lift the head again. Good. And come back down.
And should that gap be equal all the way down?
No, it's often bigger above because the fascial connections are, the transversus is giving us fascia here as well, which it doesn't do higher up. So the propensity for gaps higher up is higher.
Right.
So it's much more prevalent that we have got bigger gaps on the top, just because we haven't got that many fascial layers coming together. Okay. So I'd palpate all the way down. Then I would palpate the sides of the rectus sheath. So if you just lift your head again and come back down, and then I would palpate these so between the lowest rib and the iliac crest. I'd palpate those for densities because they're areas that can be problematic. And then I can palpate along the inguinal band until I come to the symphysis pubis. And the symphysis pubis is a bit of a hot spot for that. So I want to just palpate the skin against your bone over your symphysis. Yep. Is that okay?
Of course.
When you say a hot spot?
Because so many fascial layers come together. So on the symphysis, we've got we've got visceral fascia coming over that. So we've got in women the round ligament of the uterus that comes out of the inguinal canal and then blends with the connective tissue of the labia and the symphysis. But we've also got obviously the rectus muscles, the other abdominal muscles, so all of those fascias will blend there. And then we've got fascia from the adductors that will blend into there, and fascias from the or slips from the fascia lata that will blend there. Yes. So you could have a lower extremity dysfunction because of the abdominal dysfunction, or you could have an abdominal dysfunction because of the lower extremity dysfunction. It could go both ways. It's a real crossover point, similar to the one I showed near the xiphoid, which we'll come to in a minute.